All right, so in this episode, we're going to do electrolytes and the ECG, something a little bit nerdier. For those who are not why people and don't care to know why things happen, I can sum it up in literally 10 seconds, which is sodium doesn't really affect the ECG that much. Calcium affects your ST segment, and potassium affects your T waves. That's pretty much the down and dirty on it. If you want to know why, stick around. We'll go through it a little bit. So to talk about this, we're going to talk about electrolytes, and I could do a whole episode on the cell membrane and how electrolytes flow. And if any of you are my former students, you're having PTSD right now, remembering me discuss in depth that Goldman equation that you can see at the top there, which is how we calculate membrane voltage in cells. And in short, we take a bunch of charged particles and we put them on either side of the cell membrane, and that creates an electrical potential, and then we fluctuate that to send signals throughout the heart. And so there's a direct correlation between which electrolytes are moving, which channels are open, and what's happening on the EKG. And so the first very basic thing to understand is that there's actually two types of cells in the heart that generate electricity. Your myocytes, which are the muscle cells, they generate the majority of the electrical output in the heart. And so if you remember how ECGs work, how big or how upright or down a waveform is, the overall magnitude is just representative of how much energy the electrode is receiving. And so because of that, the muscle cells pretty much they dictate how big a waveform is going to be. If you have a bunch of muscle cells, your waveforms are probably going to be bigger, right? So people who have an enlarged ventricle, their QRS complexes tend to be bigger. There's a whole bunch more to it that we'll go into maybe on a different episode, but that's the general idea. The other set of cells, which are your nodal cells, which make up the conductive network, are the other cells in the heart, and they operate on different electrolyte channels, and we'll talk about that in a second here. But since the muscle cells make up the majority, they're going to be the ones who dictate what you see on the waveform. So I kind of made a little cheat sheet for you there. You can see at the top, that's a graph representing the voltage change in the cell membrane over time. And so this is the action potential that your muscle cells undergo. And I have way oversimplified it. There's a bunch of other stuff going on, but from a very high level view, there's three distinct phases, which is depolarization, what we call the plateau phase, and then repolarization. And there's a major electrolyte that dictates what's going on the ECG with each phase. Again, for any of the nerds out there who are raging at their computer right now, I'm aware I'm way oversimplifying this, but this is going to correlate directly with the ECG, because you can't argue. Sodium affects the P waves and it affects the QRS complexes. Calcium affects the ST segment, and potassium affects the T waves. That's just how it's really that simple. So we'll kind of parse through each one of these and give some examples. All right, so sodium in of itself doesn't typically have a major effect on the ECG. Can cause arrhythmias in severe cases, but you're more likely to see neurologic changes way before, so things like seizures. Part of that is attributed to the fact that sodium is just so much more prevalent outside the cell in comparison to some of the other electrolytes, and so you can have pretty big fluctuations and it doesn't show major effects. Now, where you can see effects pretty significantly on the ECG is when you start developing toxicity of some sort of sodium channel blocking drug, and that can be your classic drugs like lidocaine, procainamide, and some of your other antiarrhythmics, some of your numbing agents like benzocaine, cocaine. Some people don't realize it's also a sodium channel blocker. One thing to note is with sodium channel blocking drugs, some have a propensity to be more neurotoxic versus cardiotoxic. So it kind of depends. Lidocaine is a good example. Lidocaine, typically you're going to develop neurotoxic effects before you would see cardiotoxic effects. And that typically occurs around 5 milligrams per kilogram. Most common way you're going to see that is typically like a provider doing like multiple local anesthetic injections and exceeding the maximum amount, and so you can have like seizure-like activity. But some drugs will cause cardiotoxic sodium channel blockade first, and some of them are not drugs you would expect. The ECG you see up there, this is actually a diethylhydramine overdose. The patient took around 7.5 grams. And so although Benadryl is primarily an antihistamine, it has a bunch of other side effects. And two very unfortunate ones are that it's a potent anticholinergic, and then it has, at severe levels, sodium channel blocking effects, and that's what you're seeing there. Since sodium is the primary electrolyte in motion during depolarization of the muscle cells, then as your ventricles depolarize, that's represented on the ECG by your QRS complex. And so if I slow the influx of sodium in, you're going to end up with a wide QRS. And then if you sprinkle in some anticholinergic toxicity, you get the fast heart rate, and that combo makes Benadryl overdose along with tricyclic antidepressants as toxidromes that can mimic ventricular tachycardia. Both cause the wide QRS through sodium channel diseasing, and then increased heart rate through anticholinergic syndrome. And so that can lead to this wide QRS with no P waves. That's fast, and you may mistake it for VTach. And the problem there is well, what do we use to treat stable ventricular tachycardia? And some of those drugs happen to be sodium channel blockers. So you can have some QTC prolongation. Certainly amiodarone would be potentially the most dangerous drug to give in this case, because it's the most likely to prolong your QT interval. And then you would be at risk of causing big time problems, including torsades or even asystole, depending on the patient's reaction. So instead, anytime you suspect sodium channel blockade, you fix it with sodium. So you would give intravenous sodium bicarb, and depending on the toxicity, they often require several doses. This patient received several amps of sodium bicarb before their ECG started to show any improvement or hemodynamic improvement as well. And that's typically true of any of those cardiotoxic sodium channel blockers. So again, anytime you see a wide, fast rhythm, always in the back of your mind, make sure that you're not dealing with sodium channel blocker toxicity before you commit to ventricular tachycardia. And if you aren't sure, you can give essentially much safer to give an amp of bicarb to somebody than it is to commit to a dose of amiodarone if we're doing a risk-benefit analysis. Of course, you're going to run into monomorphic ventricular tachycardia far more often in the emergency room or in the back of an ambulance than you are sodium channel blocker toxicity. So, of course, it's physical exam, common sense. Is your patient a 60-year-old with chest pain and heart disease? It's probably VTach. Is it, a 19-year-old suicide attempt by overdose? Well, it's probably more likely to be a toxicity. So use your pretest probability to help kind of differentiate. If you are truly unsure if it's really that patient that could go either way, and you want to commit to using a antiarrhythmic, surprisingly lidocaine is probably your safest bet, because it's the least likely out of your ventricular antiarrhythmics to prolong your QT interval, and so you're less likely, it has much less of a torsadogenic effect compared to some of the other agents that we use. All right, next up is calcium. Again, as I said at the beginning, the down and dirty calcium, elevated calcium levels are going to shorten the ST segment, and low calcium levels are going to lengthen it. Typically, hypercalcemia is not going to have, a short ST segment is not going to have too much of a major physiologic effect on the patient. You're going to run into other issues with hypercalcemia, but hypocalcemia, the big concern there is because I'm lengthening the ST segment, I'm prolonging the QT interval, and of course that increases the likelihood that your patient may develop torsades. So as you can see on the ECGs up here, I've got two examples. The one on the top is hypocalcemia. You can see that long ST segment. You can see your QT interval is a little bit prolonged, predisposing that patient to torsades. And then on the bottom, you can see hypercalcemia, where the T wave is right up on there. One thing that I always felt like with hypercalcemia is it kind of could maybe be mistaken as like an early MI. If you're looking at like V2 in this ECG here, you can see you got a big T wave. T wave looks kind of symmetric, and it's right up on that QRS complex, which is could mimic an early anterior MI. Of course, it would go to patient presentation. Causes of hypocalcemia and hypercalcemia. Your number one differential besides dehydration is going to be some sort of parathyroid disease. Your parathyroid hormone is what controls calcium levels, and so if you have a tumor on the parathyroid, that's one of your major causes of calcium changes in a patient. And then we have potassium. Potassium is one of my favorite electrolyte disturbances to talk about. There's so many cool different presentations that you can see. We run into it fairly frequently, I would say, as far as potentially lethal electrolyte abnormalities that we encounter in the field or in the ED. This is one we see probably the most often. And if you catch it, you can save a human life. And if you miss it, you can really jeopardize that patient. If your patient develops potassium fluctuations, you really have to identify that quickly and provide the right therapy. And kind of in the same guise as sodium channel blocker toxicity, it can mimic some other diseases. And if you miss it, some of the therapies that it mimics could be potentially harmful. So we definitely want to pay attention to that and screen for it. And in the ED, obviously, or in hospital, or in the back of an ambulance, if you have point of care lab testing, obviously the easiest way is to not use the ECG. That's not the most sensitive test to determine a patient's potassium level. That's just to measure their serum potassium level. So if you're getting weird T-wave changes and your patient's potassium's 8, well, hey, you figured out your problem. But in the absence of that, we are kind of reliant on our physical exam and then the ECG to kind of help corroborate. And so again, the potassium represents repolarization. Ventricular repolarization on the ECG is represented by the T-wave. And so your potassium is going to affect the shape and size of your T-wave. And this one's actually pretty easy to remember. If you have high potassium, you have high T waves. If you have low potassium, you have low T waves. Now, to get a little bit more specific about presentation, hypokalemia, low potassium, you're going to end up with a wide, low, rolling T wave that's biphasic typically. Unlike Wellenstein, which is the other manifestation of biphasic T waves that you can encounter, Wellenstein goes up and then down with their T waves. Hypokalemia should go down and then up, and that terminal end is often sometimes called a U wave as well. It's just the other part of the T wave. It's just widening and then becoming biphasic on there. So you can see that in the first example there. Obviously, the big concern with hypokalemia, you can see how wide and big those T waves are, and they're butting right up against the following P wave and QRS. And so that's going to predispose your patient to torsades, just like hypocalcemia. Oftentimes, or maybe not often, but there's a risk that you might develop both hypocalcemia and hypokalemia, in which case you would certainly be at risk of developing torsades. And then on the right, you can see kind of the early signs of hyperkalemia. You can see the tall, narrow T waves because we have a hyperactive repolarization phase. Now, what's interesting about hyperkalemia is early on you develop T-wave changes, but when you start to get really, really high potassiums, and that is not a linear progression. I do see some blogs and some textbooks that talk about correlating an ECG with potassium levels, and there's some correlation, but the human body is adaptable, and any patient who's developed hyperkalemia in the past, they're by default more likely to become a little bit more resilient. So patients like renal failure patients who are often develop hyperkalemia, they may not have ECG changes that occur until much later. So the ECG is not a wonderful diagnostic. Again, in the pre-hospital arena, it's kind of one of our primary diagnostics to kind of help catch. But the key thing, the very interesting part with severe hyperkalemia is the T waves start to go back down in size and the QRS widens out. Well, that seems counterintuitive, right? Because I said the QRS is represented by sodium and the T wave is represented by potassium. So why would that be? Why would severe hyperkalemia make it develop that ECG presentation? And the reason for that is that it goes back to that first slide. You saw that equation that had all the electrolytes on one side of the cell membrane and the others, and it was calculating membrane voltage. Well, the way that these electrolytes move across the cell membrane is through these proteins that are embedded in the cell wall, and they open and close based on changes in voltage. And that's true for your sodium, for your calcium, for your potassium. And so if I start stacking too much potassium outside the cell, I start to affect that membrane voltage, and the alteration that occurs causes a failure of your sodium channels. In essence, if your potassium gets high enough, you actually start to block sodium channels. They start to not open like they're supposed to. And you end up with a very similar ECG to what you see with sodium channel blocking toxicity. Things like I talked about earlier, tricyclic, antidepressant, cocaine toxicity. You can see the EKG there. That's severe hyperkalemia. It's very hard to tell based on the ECG at this case. But here's the key distinction. When you're dealing with hyperkalemia, if you have a wide QRS, especially if you see the QRS widen, knowing that it's not your patient's normal intrinsic ECG pattern, you have an unstable myocardium. The cell membrane is unstable. Your electrolytes are all they're way too many potassiums outside the cell, which is not where potassium is supposed to be, and so your membrane voltage is messed up. And the problem with that is that these patients will often be hypotensive or in a shock state, and a lot of the therapies we use, catecholamines, pacing, resuscitative drugs, they're not going to be very effective because the heart can't react to those drugs. Your heart cannot react to epinephrine if your cell membrane voltage is so messed up, and so you have to stabilize that. You have to normalize that, and in order to do that, you've got to put the right electrolytes on the outside of the cell. And the number one electrolyte that's going to help is calcium. And so with hyperkalemia, it's an interesting disease process, and there's really three distinct segments of therapy that we do. And so anytime we're dealing with hyperkalemia and you have an unstable myocardium, which you would denote with any wide QRS associated with it, that patient should receive calcium. And in the emergent setting, they should be getting calcium chloride. I get some questions about between calcium chloride versus calcium gluconate. It's the calcium we want, whether it's chloride that it's bound to or gluconate, doesn't really matter from a therapeutic standpoint, other than it can be misleading because they both are dosed as 1 gram. And so if you look at it, you might go, oh, well, 1 gram of calcium chloride, 1 gram of calcium gluconate, who cares? Well, because the calcium is bound to a chloride atom instead of a gluconate molecule, the overall contribution to the total molecular weight in calcium chloride that calcium provides in calcium chloride is much greater. And so to make a bunch of fancy stuff simple, there's just more calcium, what we would call elemental calcium, in calcium chloride compared to gluconate. And so you get more bang for your buck. You want to use calcium chloride, you're going to get more. And so if you have any suspicion of hyperkalemia, or you can confirm hyperkalemia with laboratory testing, and you see a wide QRS, your first therapy should be calcium. This is kind of one of my critiques of like ACLS. If I have a patient who's hyperkalemic and they code in front of me and their QRS widens, the first drug I'm going to give is going to be calcium all day long, because that we know that that's the causative of the arrest there. Now, a couple things with calcium. If you're giving calcium chloride intravenously, we have to be careful because it can cause an extravasation injury. So we want to make sure we have a good patent IV site or an IO. Remember, an IO is basically central access, and you can push essentially anything through that. And then the other thing to note, there's a lot of fear around the electrolytes, especially in like the pre-hospital arena. I see a lot of pre-hospital providers who they have no problems giving drugs like cardizem or amiodarone or some of these antiarrhythmics, but then they balk at giving electrolytes. And the reality should be much backwards. If you give an amp of calcium chloride, you on average are going to raise your patient's total calcium by about 1 to maybe 1.5 milligrams per deciliter, which a normal range is about 8 to 10. So it's not that that's not a substantial amount, but that's not that much. And you're certainly not going to cause massive hypercalcemia. And anyone who tries to argue that is silly. That's very unlikely. The risk benefit is so one-sided that you should be pretty loose with your calcium in that case. I'm not advocating you give every person on the planet calcium, but certainly if you have a high index of suspicion of hyperkalemia, and you see a wide QRS and a patient who is presenting with hemodynamic instability, it's a no-brainer, in my opinion. And you can consider bicarb as well. It is less effective, and then also too, you need to be careful if you're pushing it through the same IV. So we would be flushing it very much. When you do give calcium, please keep in mind too, like it's not a denizen. I know pre-hospital providers especially were kind of quick and rapid with our IV pushes. That is going to be very unpleasant for your patient if they are conscious. So slow IV push, 60 seconds, 2 minutes, slow through a good patent IV. And just as a quick review on hyper K, if you do have hyper K, your primary therapies to actually reduce your serum potassium is the administration of insulin. And you can also concomitantly give high dose albuterol or high dose beta 2 adrenergic therapy. So when I say high dose albuterol, I'm talking somewhere around 10 to 20 milligrams, which would drop your potassium by about 0.6 to 1. Which again, normal values are about 3.5 to 5. So that's a pretty substantial reduction, and those effects last for about an hour or so. Your insulin dose is 0.1 units per kg of fast acting. And then in certain cases, you'll actually also remove potassium from the body. So those are patients who are typically develop renal failure, where the potassium's building up in their body. And in those cases, you may actually need to eliminate it completely, which you would do with like diuretics like Lasix or Kayexalate. Basically, you have to your body has to excrete the potassium in some way or the other. So not super fun, especially for us transfer people. We always love Kayexalate being administered right before we load them into the back of an ambulance. But that's your 3 criteria. And as a quick blurb, just to kind of give you an idea, potassium exists in the body in cells. So any disease that causes cellular destruction is going to predispose that patient to hyperkalemia. So those are things like burns, rhabdo, crush injuries. And then the other disease group that can cause hyperkalemia is anything that causes the protein channels that are designed to keep the potassium in the cell cause them to fail. And the number one cause of that is actually acidosis. So severe metabolic acidosis can predispose the patient to developing hyper-K. So those can be things like DKA, sepsis. And DKA is kind of an interesting one because oftentimes when we think of DKA, we think hypokalemia because they will usually start the disease process low through their polyuria, but over time, if their acidosis worsens, they can actually become hyperkalemic as well. So again, review, hyper-K, wide QRS, give calcium. If you have a narrow QRS, we're starting with insulin and then potentially albuterol. So if you don't have access to insulin, we're doing albuterol, we're doing high dose. If you do carry terbutaline or Zopanex, you can consider those therapies as well. Okay, and the last little bit here. At the beginning, I started talking about pacemaker or nodal cells, and so I just wanted to cycle back and go over that because you can see their slope phase is a little bit different. They don't have, well, for one thing, their resting phase is not flat. You can see that it is slanted upwards. That's because these cells have automaticity, right? These are your SA node, your AV node, your bundle of His, your Purkinje fibers, your bundle branches, the Bachmann bundle. This is the conductive network within the heart, and they have that inherent ability to spontaneously fire. And that happens because calcium kind of leaks into the cell. They don't lock it out tight like you see with the muscle cells, and so they fire on their own. And you can kind of see that actually makes a little bit of a sinusoidal pattern, and it oscillates to a specific frequency. If I took a nodal cell out of the SA node and I plotted that, it would cycle through that graph you see on there. It would cycle through those waves 60 to 100 times a minute because that's the intrinsic firing rate for the SA node. If I removed one of the cells from the AV node, it would go at 40 to 60 because that's the inherent firing rate of the AV or junctional rhythms. If I took it out of the Purkinje system, you've probably already guessed it would be 20 to 40. And then also, if I were to take one of those cells and I were to squirt some epinephrine on it, well, it would cycle faster. If I squirted acetylcholine on it, it would cycle more slowly. That's how our body uses our endogenous hormones and neurotransmitters to affect our heart rate through vagal stimulation or sympathetic stimulation. And then we can directly affect this with certain drugs. You can see there that unlike muscle cells, which fire on sodium, these cells fire and depolarize on calcium. And that actually kind of goes back to our ACLS algorithms and why you see some differences in drug choices. If I have tachydysrhythmias that manifest in nodal cells, things like SVT, AFib, aflutter, well, we tend to trial calcium channel blockers, specifically non-dihydropyridine calcium channel blockers like cardizem or verapamil. And you can see why. If I give you a drug like cardizem, that's going to slow calcium's ability to leak in and fire the nodal cell, which is going to slow conduction and slow heart rate. And if I develop dysrhythmias that occur in the muscle cells, those are things like ventricular tachycardia. Well, then you notice we typically give sodium channel blocking drugs like lidocaine, procainamide, etc. So that's just kind of that's the two different types of cells, and that's kind of the ideology behind the fundamental parts of your ACS algorithm and why we select certain drug choices. So it goes without saying that calcium is kind of a prevalent electrolyte in all the different phases. And so on top of having ST changes with calcium, you can also start to get automatistic changes and heart rate changes associated with significant derivations in your serum calcium levels. All right, so I lied and said that this was going to be quick, and then 25 minutes later, we're still talking about this. So um, just a kind of a recap all the way to the back. So the part that you wanted from this, when I'm looking at an EKG, how can I use the EKG to kind of identify major electrolyte changes? And so we're just kind of closing with that. So sodium affects the P wave and the QRS because it's the electrolyte in motion during depolarization. So atrial depolarization would be your P wave, ventricular would be your QRS. Calcium affects the ST segment, which is that plateau phase. So high calcium equals short ST, low calcium, long ST. And then with potassium, it affects T waves. And so if I have high potassium, I have tall, narrow T waves. If I have low potassium, I have low biphasic T waves that go down and then up. So there it is, electrolytes summed up for your ECG. Thanks, guys.